the emergency medicine channel. 47-year-old, non-case of CKD, stage 5, 3/7 dialysis, primary hyperoxaluria, came to ER with alleged history of DSH with intake of 7 tablets of sacubitril 26 mg and valsartan 24 mg of brand name Vimada 50 mg 45 minutes before the arrival to ER.
Can you tell about sacubitril valsartan combination? This is a new drug combination.
Sacubitril and valsartan is a new drug in the class of angiotensin 2 receptor blocker plus nephrolysin inhibitor.
Okay.
ARNI.
Okay.
Here valsartan is a ARB and sacubitril is a nephrolysin inhibitor.
Where it is primarily used, this drug?
Primarily used in heart failure.
Cardiac. This is a newer drug in cardiac failure. Okay.
Initial 10-second assessment, patient is conscious oriented, airway patent, able to complete one complete sentence, no stridor, pooling of secretion or gargling, breathing, respiratory rate of 24 per minute, saturation of 98% in room air, on auscultation bilateral air entry present, circulation wise heart rate of 60 per minute, BP of 100/70 and all peripheral pulses palpable, disability GRBS was 60 mg
so
per
this
day.
is very important. When the patient is admitted with a toxicity of a drug which can produce hypertension, BP, pulse, lactate, all these things are very important.
GRBS was 60 mg per DL, so we given 25% dextrose IV stat. Then GCS was
Can
full.
this drug produce hypoglycemia?
No, sir.
As such, it will not produce hypoglycemia.
Pupil was bilaterally equal. Exposure temperature.
Can hypoglycemia worsen this situation?
Yes, sir.
How?
Hypoglycemia can decrease sensorium, and we have to.
A patient with cardiac failure, can hypoglycemia worsen the situation or not? You think about hypoglycemia complications, or how do the patient present with hypoglycemia, how do it is going to affect your heart?
Ischemia can hypoglycemia.
Hypoglycemia, what is the first response? Tachycardia.
Tachycardia.
That is going to reduce your pumping again. And second thing is blood is already having less glucose. Pumping is low. So the low glucose blood will be pumped with more effort. The effort of the heart will increase. Again, all these things will contribute for further cardiac failure. So hypoglycemia is the one thing which should be corrected fast. Okay. Most of the situations, especially when there is a cardiac failure.
Adjuvant to primary survey, we did an ABG which shows no acute acid-base disorder, but a creatinine of 5.3 and potassium of 5.9. No lactate was
it previously like that or?
Already CKD patient.
Okay, it's a non-CKD patient. It may be high. Potassium is?
Potassium is 5.9.
Okay. Is it contributed by the drug or previously it was high?
Previously it was due dialysis on the day.
So maybe it is high. The drug can also contribute
to that. Sample history: 47-year-old, non-case of CKD, dialysis 3/7, resistant cardiac failure with pleural effusion. Last echo showing dilated aortic arch LA and LV global hypokinesia with moderate LV. Alleged history of DSH patient bystander gives an history of patient intaking sacubitril and valsartan combination due to personal issues. 7 tablets was taken.
Is that 7 tablets are lethal dose or not? That is a first thing you should address. How much each tablet contains valsartan sacubitril?
Sacubitril, in heart failure, we will start with the dose.
How much this tablet contains?
Patient took
each tablet.
Each sacubitril is 26 mg and valsartan is 24 mg.
24. How much is required for a toxicity?
Up to 96 per 1 up to 97 mg per 107 mg can be given.
It is up to nearly 500 milligram will not produce any effect. Okay, only thing is patient is having renal failure that can contribute to the problem. But his kidneys are removing sacubitril valsartan from body or something? His dialysis can remove.
No, dialysis can they have
so kidneys are not the major factor in removal of the drug, and even dialysis cannot remove. So 9 tablets is not a problem in clinical practice, and renal failure is not aggravate the problem also. Okay. Only thing is potassium hyperkalemia will be a major problem when the patient is already having renal failure with sacubitril dose.
Then, since the patient came within 1 hour of intake, we did a gastric lavage with activated charcoal. 50 gram was given.
Okay.
Toxicology analysis was sent. It's a non-CKD patient, but BP was in a lower range. So we started.
What is the
on
importance of toxicology analysis in this patient?
any other toxins.
Okay. So we know that this patient is already taken this drug and it is not in a lethal dose. It is not going to affect the patient's condition at all. But we want to know whether any other drug is taken along with this drug. Okay, that's all. And we are not, mostly we are not doing the quantitative analysis of the drug overdose here. We are only telling qualitatively whether it is there or not. Quantitatively, we have to ask for another test. Okay.
We started him on oral and we admitted him under in ICU and initiated HD was done and other anti-hyperkalemic measures was taken.
Okay.
When patient was stable, we refer the patient to the nephro department for further assessment.
Okay, so can you tell me about sacubitril valsartan indication, contraindication, adverse effects, toxicity?
This ARNI, sacubitril valsartan, is mostly we use for heart failure in a decreased ejection fraction and also on a normal, if it is in preserved ejection fraction heart failure.
What is the action of this drug?
ARB,
why we are using
valsartan can be ARB, and this neprolysin breaks down. Neprolysin inhibitor prevents the breakdown of vasoactive peptides which can lead to vasodilatation and natriuresis, which is used for improving of the cardiovascular function. Can be done.
What is it called? What is the problem? What is the problem in the heart which is going to corrected by AC inhibitors, ARBs, or neprolysin inhibitor? Vasoconstriction. What is that term? Ventricular remodeling. Okay. So we should know that ventricular remodeling can be prevented by all these drugs, and this is a newer addition to the regime. Okay.
So then
so indications are cardiac, heart failure.
Preserved and decreased ejection fraction.
Okay. Contraindications,
we can't give it if any hypersensitivity to the drugs or history of angioedema with the ACE inhibitor or ARB, we can't use this drug.
Okay.
When within 36 hours window, like after stopping ACE inhibitor or we are planning to restart ACE inhibitor for a period of 36 hours, we are not supposed to give.
Okay, that can produce hypertension. The other contraindication, major contraindication is what?
By BPI.
Major contraindications.
Pregnancy.
For one is pregnancy. Okay, breastfeeding, pregnancy. Second thing is
severe renal
failure. Renal failure, creatinine more than 3. Should avoid this type of drugs. Then
potassium more than 5. Also
high levels of hyperkalemia due to any cause. Then renal artery stenosis. Okay, so these are the common contraindication, but pregnancy is a major that we should not forget, because the pregnancy only contraindicated drug are AC inhibitors, ARB, and this newer addition. Okay.
It can affect renin-angiotensin system of the baby and can cause hypertension. Then adverse effect, most common side effects are acute kidney failure can occur because it can increase creatinine levels. Then angioedema, and neprolysin inhibitors can increase bradykinin levels, so angioedema can occur. Then hyperkalemia. So then hypotension is also increased. So any poisoning, we have to manage hypokalemia, and antihypertensive measures should be taken to initiate.
So you have started noradrenaline here. Okay.
Since patient's BP is already CKD patient, low BP, so and also hypotension, we started on noradrenaline.
Do you think that this dose can produce hypertension.
No, sir. So, hypertension, if in a normal patient, after starting drugs, almost like 18 hours later, only hypertension can occur. So, underlying.
Hypertension may not be because of this
Because of
drug.
this drug.
It will be very rarely it can produce hypertension. Okay. So is it dialysable, this toxin?
Toxin is not dialysable.
No, this drug is not
Drug
dialysable.
is not like have a high
Protein
binding capacity.
Okay, so it is not dialysable.
Dialysable.
Okay. Anything else you want to add?
Other side effects like more than 10% people can cause hypertension, hyperkalemia, increase creatinine. In 1 to 10% patient can also cause decrease in hematocrit and decrease in HB and orthostatic hypotension, and some can cause hypertension.
What is first dose hypertension?
First dose, after initiation of first dose, we'll get orthostatic hypotension.
Which all drugs?
Mostly in alpha inhibitors.
AC inhibitor ARB is one of the common drug. Then, like you told, alpha blockers can produce. Then what else? Alpha blocker like prazosine. These are the common drugs. But AC inhibitor ARB, all these drugs can produce first dose hypertension. That's why we advise the patient not to get up suddenly from the bed immediately after taking the drug. Okay. Anything else? Okay. Thank you. After listening